Hello and welcome to Lecture 5 in our series of 6 lectures on the human reproductive system. Today we're going to cover mammary glands and oogenesis. So we're working our way into the female side of life. So as we look through this and as you're working, please remember to pray for others and be able to tell God your gratitude for what you have. Count your blessings. So let's get started. All right, mammary glands. Mammary glands are in males and females because we are mammals. I had a student at A&M who was one of the premier football players at the time, and he went on to play professional football. He was in my freshman biology lab, and we were talking about sexual characteristics, and I was talking about breasts, about mammary glands, and he stood up in class and said, "I ain't got no mammary glands." And I said, "Yes, you do." He said, "No, I don't." "Yes, you do." "No, I don't." You should never argue with a fool. So I told him to go to the bathroom, lift up his shirt, and see those 2 brown spots on his chest. Those are his mammary glands. And he marched out of the classroom, came back a couple of minutes later, very sheepishly, and said, "I got tits." When you have mammary glands, yours just don't work. And yeah, it's amazing what people don't know about their own bodies. But the function of the mammary glands is to produce milk to feed the babies. These are really modified sweat glands. That pigmented skin around the nipple is called the areolar, and in women who have never been pregnant, it will probably stay a more pinkish type color or pinky, whereas in women who have been pregnant, it will darken substantially. We don't know. Maybe it is to help the baby have a target. But that's this pigmented skin around the nipple. And of course, the nipple is where the milk comes out. And the breasts are attached to the pectoralis major by ligaments, suspensory ligaments. And these ligaments will stretch as the breasts become heavy with milk or become just heavier with age. And that's why our breasts sag, ladies. So the lobules have alveoli, and alveoli are actually the little gland that produces the milk. The milk goes from the alveoli into the lactiferous ducts, into the lactiferous sinuses, and then that has an opening to the to the outside. And breast size will increase during pregnancy and as the mother nurses the baby because it is full of milk. But aside from that, breast size is due to the amount of fat deposits. And so the larger the breast, the more fat is in the breast. And this is going to accumulate over time. And we look at this picture, and really what you need to know is what's a lobe, where's the areolar, where's the nipple, and where are the alveoli. So it's a pretty straightforward gland, and I think it's fascinating that it's a modified sweat gland. It's pretty cool. The most common malignancy and the most common cause of cancer death in the United States for women is invasive breast cancer. And about 13% of us will develop it. Usually, if a woman is doing a good job of examining her breasts every month, just pick the same time each month to examine your breast. Feel for lumps and bumps. Nearly every woman has some kind of small lumps and bumps in her breast, but what you need to look for is if that lump or bump gets larger or becomes painful. Some of the risk factors is you start menses early, usually before the age of 12. Late menopause. Menopause is around age 50. So if you have periods after the age of 50, no pregnancies, or first pregnancy was late in life. If there was no or very short periods of breastfeeding, and then if there's a family history of breast cancer. A friend of mine at the cancer center in Arkansas had a family history of breast cancer, and she and her sisters, her mother and her mother's sister, went in for genetic testing, and they all had the BRCA cancer gene. Her mother and her aunt developed highly metastasized breast cancer and died. One of her sisters developed breast cancer, and because they were aware of their family history, caught it early. But she and her other sister decided, forget this. Her sister had the children that she wanted, and my friend didn't want children. So they went ahead and both had double mastectomies and just got rid of their breasts so that they didn't have to be concerned about developing breast cancer. And they both wore prostheses so that they looked like women. It's very important for the mental health. So the vast majority of us, though, who get breast cancer have no known risk factors. We just have to be very vigilant and examine the breast every month looking for changes. Usually self-detection, a mammography, and I know this says the American Cancer Society recommends screening every year for women age 40 and over. If you have a really good gynecologist, they will take a baseline mammogram when you're in your around 25 to 30. I think that it's really important to have a mammogram just to make sure. A lot of insurance companies will pay for one mammogram every 3 years until you hit 55, and then at age 55 they recommend it every other year, and then, or if you have known risk factors, then every year. Notice that the Prevention Task Force wants to delay mammography until age 50. Too many of our women have breast cancer in their late 30s and early 40s. I would be much more cautious. So you can see here's the mammogram machine, and basically what it does, ladies, is you put your breast up on this platform, and a plate comes down and squishes it as flat as they can get it, and then they take pictures. And they take pictures at different angles. And what they're looking for is, do you have any what they call hot spots, because they show up as white. So an area that is growing. And this shows you a normal breast and a breast that has a tumor in it. It's not pleasant. You can prepare for it, ladies, by opening up your refrigerator door, or if you're tall, your freezer door, and put your breast in there and slam it several times to help you get used to the pressure. That's a joke. Not really. How do we treat breast cancer? Usually you can do a lumpectomy. They can take the breast. They can do radiation, chemotherapy. They're going to check the surrounding lymph nodes in the axilla, the axillary regions, to see if it has spread through the lymph nodes. A radical mastectomy removes the breast with all the underlying muscle, fascia, and associated lymph nodes. A lot of times a simple mastectomy will do, so you only remove the breast tissue with some axillary lymph nodes. A lumpectomy is that you remove the tumor. Usually with a lumpectomy, you're going to go through chemo or radiation therapy. It depends. Some women get breast reconstruction, and others opt to just use a bra that has prosthesis in it. Okay, so now's a good time to stretch and take a break, and we're going to go through female reproductive physiology. And this has to be broken up into 2 lectures, because we're a complicated creature, ladies. Guys, it's just really straightforward, but women are complicated. So just get ready. Oogenesis is meiosis. Oogenesis is going to result in 1 ova that is haploid and 3 polar bodies. The polar bodies are going to be reabsorbed by the body. So our oogenesis begins while we're a fetus. Okay? So the oogonia, which are going to be the stem cells, are going to divide by mitosis to produce primary oocytes that will undergo meiosis 1. Then after meiosis 1, they're called secondary oocytes that undergo mitosis 2. And the gamete is going to be called an ova. An ova. So one of the 4 gametes that are produced, one will become the ova that is capable of fertilization. The other 3 become what we call polar bodies, and they are reabsorbed by the body. You need to know these 3 differences between oogenesis and spermatogenesis. Okay, production of primary oocytes occurs only in the fetus, in the female. Primary oocytes are produced in the fetus. In the primary oocytes, meiosis is arrested in late prophase 1. Late prophase 1. Okay, so it's going to be arrested in meiosis 1, late prophase 1, and it will stay there until activated by estrogen and and LH. If it's stimulated, then it will undergo meiosis to produce secondary oocytes, okay? And it will be arrested, that secondary oocyte will be arrested in metaphase 2, and it will only be completed once the sperm penetrates the oocyte, the ova, and that will cause the ova to continue meiosis so that there is a polar body given off and extruded, and that only leaves the ova pronucleus that is ready to join with the sperm pronucleus. Okay, isn't that fascinating? Isn't that fascinating? Okay, so in the ovary we have the ovarian follicle, the follicle. Guess what follicle stimulating hormone does in females? Stimulates the follicles. So in the follicle, you have the pregranulosa cells, okay, if it's a single layer of cells. But if it's more than one layer, then they're called granulosa cells. And the follicles will go through these stages of development. Primordial follicle, where there's a single layer of squamous pregranulosa cells surrounding the primary oocyte. Primordial. It's only got one layer of granulocytes. Okay? And then with proper stimulation, then you're going to see the primordial follicle, which contains the primary oocyte, undergo meiosis to produce what? A secondary oocyte. So primary follicles have a single layer of the pregranulosa cells, primary oocyte. Secondary follicles have multiple layers of granulosa cells surrounding a primary oocyte. And then the follicles that are going to be stimulated to mature become what we call vesicular follicles, or also known as tertiary. I was taught Graphian, but remember, we're not learning things by people's names anymore. So when we look at a tertiary follicle, it has a fluid-filled cavity, and this is called an antrum. So before ovulation, the primary oocyte is going to undergo meiosis and produce the secondary oocyte. And so what we have here in the green box, you have the primary follicle, which will undergo meiosis and produce the secondary, primary follicle, secondary follicle. The secondary follicle is in the kind of yellowish green, all right, has the tertiary follicle. It will undergo meiosis 1 just before ovulation. Okay, so that means that before ovulation you get a secondary oocyte that's arrested in metaphase 2 and a polar body. After ovulation, if the sperm penetrates the egg, then the oocyte, secondary oocyte, will undergo meiosis, complete meiosis 2, give off a polar body, and have what we call a pronucleus in the ovum. That's weird, but that's how it works in humans. All right. So what happens to the follicle after ovulation? It will develop into what we call the corpus luteum. Luteum means yellow. Corpus means body. So we have this yellow body. So if a follicle is not stimulated, then it'll undergo atresia. If it's stimulated and ovulation occurs, then we have the formation of the corpus luteum. Notice it says that each month after puberty, a select few primary oocytes are activated by high levels of FSH. FSH, follicle stimulating hormones. Okay? One will become a dominant follicle. How does it become a dominant follicle? Not really sure. After meiosis 1 is completed, you have a polar body, a secondary oocyte. Remember, the secondary oocyte arrests in metaphase 2 until the sperm penetrates it, and then it will undergo the rest of meiosis with an ovum and a secondary polar body. If fertilization does not take place, then, if the sperm doesn't penetrate, then the oocyte will degenerate and be reabsorbed by the body. Why is the ovum so large? Because it's got to have all the cellular organelles and enough stored energy for the zygote to survive the 6 to 7 day journey into the uterus, where it will implant into the wall of the uterus. Okay, so we've been through this. So what we look at when we compare spermatogenesis with oogenesis, is spermatogenesis is going to form 4 viable sperm, while oogenesis produces 1 viable gamete. Oogenesis begins early in fetal life, ends in menopause. Spermatogenesis begins at puberty and goes into old age, and by old age we're talking 70s and 80s. Spermatogenesis has very few mutations. Oogenesis has a mutation rate of about 20%. So think about, why is that so high? You're right. It's because the eggs, the ova, are arrested in meiosis. Those eggs, those ova, are older than you are. The ova in your ovaries, ladies, are older than you are. Because why? They formed while you were a fetus in your mother's womb. Think about that. So there's a lot more mutation rates because they're just stinking old. This is a good table. You might want to mark it in your book and look at it. Look at that. Total time to produce 1 gamete, female, 13 to 50 years. Good grief. All right. Men will produce more than 1 trillion sperm in their lifetime. Ladies, we produce about less than 500 ova. Okay, so they say here wrong error rate is wrong number of chromosomes. All right, pretty neat, pretty neat. So here are the stages. I would expect you to be able to identify the center picture and pick out primordial versus primary, secondary, tertiary. Well, the 4B is what I would pick out to show you as tertiary. And then the corpus luteum, So, the ovarian cycle is going to happen about once every 28 days. Please know that that is an average. Some women, it's faster. Other women, it takes a little bit longer. But it has to do with maturation of the ova. So when we look at this, we have the follicular phase, which is day 1 to day 14, okay? And so the follicle's growing. And then the luteal phase, and that's from day 14 to day 28. And think of luteal, think of corpus luteum. So I think it's interesting that the follicular phase can vary, but the luteal phase is always 14 days from ovulation to the end of the cycle. So during the follicular phase, you have, like we said, a dominant follicle. FSH levels are going to stimulate the follicle to grow. All right. The primary oocyte completes meiosis 1. Then the granulosa cells send a signal to the oocyte, causing it to stop meiosis. With ovulation, the follicle has migrated to the cortex, to the outer layer of the ovary, and it will merge with the cortex and balloon out, and it will rupture. The ovarian wall ruptures, and it releases the egg into the peritoneum. And at this time, then the fimbriae of the fallopian tubes or the uterine tubes are undulating, and as they do that, they cause a wave, okay, and they're pulling the egg into the infundibulum so that it can start its journey down the uterine tubes and into the uterus. And we'll get to that in a little bit later. Mitzelschmerz. What a name. The twinge of pain sometimes felt at ovulation by some women. You feel it in your lower back where your ovaries are, and some women will have a little bit of spotting of blood at ovulation, some won't. 1 to 2% of ovulations release more than one secondary oocyte, fraternal twins. Anyway, this can be genetic. If your family has a history of fraternal twins on your female side, yeah, you may be doomed. I don't know. So, the luteal phase, okay? The remaining granulosa cells and thecal cells are going to make up the corpus luteum. And what they do is that they are going to secrete progesterone and estrogen. So if no pregnancy occurs, the corpus luteum will degenerate into the corpus albicans. Albicans means white or whitish, and it's a scar. It takes about 10 days. The last 2 to 3 days of the luteal phase is called the ischemic phase, and this is where the endometrium begins to erode. If pregnancy occurs, the corpus luteum produces hormones that's going to sustain the pregnancy. Okay? We're talking about progesterone until the placenta takes over, and that's at about 3 months.